Dr. Juan Sanchez-Ramos. Hello. How are you?
Pretty good, thank you. Good morning, everybody, or good afternoon. It looks like a lot of people are up in areas where there's less humidity and less heat. It doesn't look as crowded as usual, what usually happens with this extreme weather. I have a list of questions that I got this morning. I haven't really had a chance to look at them until just a few minutes before, but fortunately they're not difficult to answer. I'll try to be logical. I organized them. They came in kind of randomly, and it would be easier if I just go about in a logical way. So number one question, which really is about number 7, how do you make a diagnostic for Parkinson's disease? I guess they mean how do you diagnose Parkinson's disease? And that's actually seems like an easy question, but the answer is not so simple. One way it is simple. Even without any laboratory tests or any chemistry, just by a good history. In other words, I would ask the patient, what are the symptoms? I would then and spend a lot of time getting the symptoms. What makes symptoms worse? When did the first symptom begin? When did the next symptom begin? How do they play together? Do they get better when you sleep? Do some of the symptoms get worse when you use your hands? Etc. So a really good history is key about the diagnosis of Parkinson's disease is based primarily on history, believe it or not. Say about 80% of the information I need to make a clinical diagnosis is based on the history. Then about 10% of the information I need to confirm the clinical diagnosis. You notice I'm saying clinical diagnosis. That means a diagnosis is made right as I examine you, at the bedside or in my office. That's what clinic means. Clinic is come from a Greek word klinikos, meaning at the bedside. So when we talk about clinic, it means a personal interaction with you. Although, as I've said, 80% of the information for making a correct diagnosis is derived from the history. So I could be on the phone, and if I gave you a really good question and answer session on the phone, I'd be 80% sure that you have Parkinson's disease or not, right? So the 10% of the exam that I would do at the clinic would be to see how you, whether or not you have tremor, just at rest, whether or not your tremor gets better if you extend your arms, whether or not the tremor is asymmetrical, is it worse on one side than the other, how fast do you tap your fingers, does the tapping decrease as you repeat it, get smaller and smaller, is there for example, a fatigue in the hand opening and closing, does it gradually peter out? Is it worse on the right side or the left side? Do you have a rigidity in your arms, neck, or neck? Does the rigidity have a cogging quality to it, like a ratchet wrench, cogwheel rigidity? Do you move really slowly? When you reach out for something, is it slow motion or is it real quick? That kind of thing. Then I have you cross your arms and then stand. How hard is it for you to stand without pushing off from the chair? When you get up from the chair, can you initiate walking right away? Do you stoop forward? Do you have a hesitation to walking? Do you not swing the arms, etc.? That's only 10% of the information I can get in that physical exam. So when I'm done with the exam, and if I see slowness of movement, cogwheel rigidity, rest tremor, or a tendency to lose balance, or tiny gait and turning in block when you turn. All I need to have 2 of those 4 to call it a Parkinson's syndrome. So I would be able to tell you after that initial visit, without any lab tests, that you have a Parkinson's syndrome. Now, what's the difference between Parkinson's syndrome and Parkinson's disease? The difference is that in Parkinson's disease, the reason that you're slow and you're rigid and you have tremor is because you haven't been making enough dopamine in part of the brain that's responsible for automatic movement. And so if you got better when I replaced dopamine, that would be Parkinson's disease. Now, with that bit of information, which would happen on the second visit or after a phone call, and you said, yes, I've been on this levodopa, carbidopa, for 2 weeks, and indeed, I get up from a chair better, I'm not so slow, then I would say, yes, you have a clinical diagnosis of Parkinson's disease, but if you didn't get better on levodopa, carbidopa, you probably have a Parkinson's syndrome that has many, many causes. So remember that simple question, question number 7, which I pushed to number 1. How do you make a diagnosis of Parkinson's disease? It's not so easy. But that's what I do. Now, here's the little fly in the ointment. It's a funny term, isn't it? We kind of get turned off when we find the fly in the ointment. Or in the soup, it's even worse. You won't go back to that restaurant. Or roach is even worse. Okay. The fly in the ointment for the diagnosis that I've just described, which is called the clinical diagnosis, is that 10% of the time, even though the diagnosis meets all those criteria, they have slowness of movement, rigidity, begins on one side and gradually gets to the other side, all of those things, and they get better on levodopa for the next 3 to 4, 5 years. They follow all those criteria, but if you look at the brains of those people, and this has been done by examining 150 brains of individuals who donated their brain to the UK Brain Bank, in other words, in London. And they correlated what they see on examination of the brain with what the clinical history was. So on each of these 150 brain specimens that were examined, they correlated, they associated with the history. And all of these patients had a clinical diagnosis of Parkinson's disease, met all the criteria, but 10% of those brains didn't really have Parkinson's disease. Now, how does a neuropathologist make the diagnosis? The neuropathologist doesn't get a history, doesn't examine, but he just looks at the brain. Do you know that pathologists know everything but a little too late? That's the story. The internists, well, I'm not going to start putting down. But anyway, the pathologists, we say they're the smartest guys, but it's always a bit late. And, you know, so what are those 10% of the cases? Well, some of those people, about 4% of those, let's say 4% of those 10%, no, 40% of those 10%, almost half, may have microvascular disease, may have tiny little strokes that went unnoticed. So of all the Parkinson's syndromes, maybe 8% are due to microvascular disease that happens just as we get older. You don't even need to have a history of high blood pressure, stroke, or diabetes. But generally, the clinical history of those cases is they begin later in life. They begin in the 70s and 80s to have the first signs of Parkinsonism. And their symptoms usually are much worse in their lower extremities, so we call it a lower body Parkinsonism. In the other cases, the bulk of the other cases that looked like Parkinson's disease in life, they met all the criteria, but the pathologist, wait a minute, they didn't have Parkinson's disease. They have multiple system atrophy. They have other things going on. They have tau neurofibrillary tangles in the midbrain. They have some amyloid plaques. They have other things going on. They have a combination of Alzheimer's and some other reason that we don't quite understand. And one of the characteristics of Parkinson's disease for neuropathologists to say, yes, this is Parkinson's disease, that they lose dopamine neurons. So, but if they've lost striatal cells where the dopamine acts on, well, that is a multiple system atrophy or striatal neurodegeneration. So there's all kinds of other reasons pathologically that there's a discrepancy in 10% of the cases between what I call Parkinson's disease in a living person and the postmortem exam. There's the other part of the postmortem exam is the presence of Lewy bodies. We always said without Lewy bodies, you can't even call it Parkinson's disease. Well, it turns out there are some cases of Parkinson's disease where no Lewy bodies appear. One is called the Parkin mutation, 2 genetic forms of the illness. The Parkin mutation and some of the LRRK2 mutations, which is a common genetic reason for having Parkinson's disease. And in those cases, they lose dopamine, right? They get better on dopamine replacement, but you look at their brain, they don't have Lewy bodies. So the pathologist is in a quandary. Is this really Parkinson's disease? So much confusion about what is the diagnosis of Parkinson's disease is that people are arguing. What are the true criteria for diagnosing Parkinson's disease? Since we as neurologists are very practical, we still base it on the clinical diagnosis. And if you're really confused because they haven't quite gotten better on dopamine replacement, we now can do DAT scans, because that allows you to see if the dopamine innervation is decreased. But in essence, the diagnosis is a clinical diagnosis. It's easy to make if you get a very, very good history. If the history is poor, if you only look at the way a person walks, you're going to be you'll have a problem. A lot of general practitioners say, the moment you walked in, I knew you had Parkinson's disease, Mr. Schwartz. Well, I examined Mr. Schwartz, and he has a gait that's small, but his arms are swinging wide. Well, it's not Parkinson's disease. Many reasons people walk in with slow steps and poor balance. From peripheral neuropathy, diabetics have this, all kinds of injuries. So that's just one question. We have 24 more questions. Are you done? No. Okay. Number 2. This was question number 8. I put as number 2. Why do neurologists choose one drug over the other in the treatment of my Parkinson's disease? And that's always an interesting question. Oftentimes your neurologist goes by what the drug rep has told them is the latest and greatest. But we have an algorithm or a plan, a strategy that we follow for treatment of Parkinson's disease. So I'm going to go through it. And this determines what drug you should use when. Right? It's not what drug to use, but when should I use it and for what purpose. So a lot of people say, oh, I have Parkinson's disease, this is what you do. No, no. If you have the syndrome of Parkinson, in other words, slowness of movement, rigidity, some tremor, but those symptoms are so early, it's only affecting your left side and your right-handed, that it doesn't impact your quality of life. Maybe a little socially embarrassing, because every now and then you'll have that little tremor, you put it in your pocket, it goes away. You'd like not to have that. That person does not need any medication to relieve symptoms. In other words, symptomatic relief is not necessary until those symptoms interfere with quality of life or everyday functions, like dressing yourself, cutting food, brushing your teeth, getting up and walking. Then you would use symptomatic therapy. By the way, I'm talking about symptomatic therapy. That's a therapy that alleviates the symptoms that are troublesome. There's another kind of therapy called neuroprotective therapy, and that won't alleviate your symptoms. That's a medicine that you'll take that may delay the need for symptomatic medicines and may actually slow down the rate of progression of the illness, the rate of gradually worsening. So if someone comes in and they have the very early stages of Parkinson's disease on the left side, they don't really need symptomatic relief because they're functioning quite well. I would put them on a neuroprotective agent that would slow progression. In the older days, and I still use it, it's selegiline, which may slow progression slightly. And now we're using rasagiline, 1 milligram. It may slow progression a bit. And a number of antioxidants and so forth, and cardio aerobic exercise. All of that is what I would recommend to a person with early Parkinson's disease who does not yet need levodopa. So the drugs that your doctor may choose to start you with is not a drug that's going to make your symptoms get better, but would be a neuroprotective agent. Then, let's say that your symptoms are bothersome. They're troubling to you. The cutoff point to decide what medicine to use, you can use levodopa, carbidopa, Sinemet, or you could use a synthetic dopamine called dopamine agonist, pramipexole, Requip, that kind of drug. What determines which one you should use? And here we have an arbitrary line based on age. If a person is young onset Parkinson's disease, what we like to say is less than 60. It used to be 40 is young, but less than 60 is young. Over 60 is older, not old. So younger and older. So if you're less than 60, we like to use a dopamine agonist and delay the levodopa, carbidopa. The reason is that when you're younger, when the diagnosis is made, you're more likely to develop involuntary movements called dyskinesias when you started initially with levodopa, carbidopa. So the most dramatic dyskinesias, which are involuntary movements that can come on at different times, are twisting, turning, dancing. They could be grimacing. Many of you know what I'm talking about. That doesn't come on right away. it comes on after a little bit of use of levodopa, maybe within a year or 3 years. And if you're young, it comes on really early. So a 26-year-old diagnosed with young onset Parkinson's disease within a year may have severe dystonia like Michael J. Fox, or Muhammad Ali had terrible facial grimacing when he got his first dose of cinnamon, the very first dose. So this is why we don't use levodopa, carbidopa in younger people. If you're 60 or over and the symptoms bother you, we go ahead and use levodopa, carbidopa to alleviate slowness and rigidity. But levodopa, carbidopa, and dopamine agonists sometimes don't touch rest tremor. So what I like to do at any age, if someone's symptoms are bothering them, and there's a lot of tremor, I might want to start with amantadine. If they're less than 60, I'll use an anticholinergic drug. I may be giving you too much information. I'm trying to give you, I'll give you the simple answer. Why do you choose one drug over another? There are rules of the game that we follow based on our experience and knowledge of the underlying disease. So unfortunately, many of your doctors, my colleagues, especially in general medicine, internal medicine, don't keep up with the changing, what we call algorithms or formulas that we follow for treating the illness. So this is why you come to a specialist who kind of understands the reasons for using this drug versus that drug. So I think I've answered enough of that. I could go on and talking about a whole bunch of other stuff about why I choose this drug for this patient, but not for that patient. One final thing is, anyone over 60 who has a lot of tremor that's not getting better with levodopa, carbidopa, I'm reluctant to use something that works really well, which is an anticholinergic drug like Artane, because it can cause memory problems, urinary retention. But if you're younger, if you're 40 or 30, and you have a lot of tremor, I'll use Artane and Cogentin. So that's the big difference. The challenge will be when medical marijuana is available, will we use medical marijuana at what stage? When you're younger, when you're older, for what conditions? In the 19th century, tincture of cannabis indica was used for slowness, rigidity, and tremor. But we don't know what the right formulation is. I was asked by the Florida Medical Association to write a course to educate physicians on the use of medical cannabis for all kinds of neurological conditions. And unfortunately, there's very little research that will guide our prescription. So if someone's having a lot of memory problems, I probably wouldn't recommend cannabis for them because it can kind of interfere with short-term memory. On the other hand, it can make you feel positive. So I don't know. But it's something that will be worked out over the next 5 years, I think, if Amendment 2 is voted upon. Right now, I don't know if you're aware of it, but right now there's a compassionate use of marijuana that allows hemp. Charlotte's Web is a strain of cannabis. It's really hemp that doesn't have any THC. In other words, it's like coffee without caffeine. And supposedly it's great for seizures in children that don't respond to other medicines, and that's why the governor signed it in. Unfortunately, the literature on that, just maybe 8 cases reported in the literature. There's a lot of publicity and anecdote. And the reason that this is law now, starting January, and so doctors will be able, and I'm helping write up the course to train doctors how to use it, is that there's no literature. It's all in animals. So, but when I reviewed for the course, I saw there's an incredible amount of literature on the use of cannabis with higher amounts of THC that doesn't have the caffeine removed, quote unquote. And that I'm working on the dosing formulations, because I think November 3rd, people can vote yes for Amendment 2 or no for Amendment 2. And I'm not going to suggest how you should vote, other than to say that the greatest amount of literature and clinical trials to support the use of cannabis for movement disorders is not based on Charlotte's Web material, which is hemp. It's based on the use of cannabis preparations like they used in the 19th century. It has a little bit more THC, and that would make me reluctant to use in people who have memory problems because it can affect that. Whereas the hemp stuff, hemp without any THC probably won't. Like if someone has a cardiac arrhythmia, I'm going to have them drink decaffeinated coffee, right? And if someone has memory issues, I'm not going to be prescribing cannabis with high THC levels. So this is a new era for American medicine because We never are trained in herbal medications. There's no training in medical school, whereas in Europe, especially in Germany, it's amazing how much more the medical education incorporates herbal medicines. And you can go to Germany and Europe and you'll find herbal medicine stores. And doctors kind of understand what, like St. John's wort, some of you heard of, it's an antidepressant. Well, you have to understand that it's not good for everyone and can interact negatively with some of your other medications. So talking about when does one doctor use what medicine for Parkinson's is going to get even more complicated when we have 3 or 4 new medications that are based on hemp or cannabis. Though I don't think that'll catch on very quickly in Florida. It'll take a while to educate the healthcare providers. Although many of my patients are all interested, many of my patients who are of the 60s generation already have experience with cannabis, and they actually want access to it in a legal way. So it'll be interesting. So I actually I was asked to write an opinion piece on this without giving how I'm going to vote on the Tampa Bay Times. And the title of the opinion piece, which was clarified, what did the legislature pass and what is this Amendment 2 all about? And I kind of clarified everything, and I titled it Educating Florida Physicians on Medical Marijuana, Medical Cannabis, and the editors who really asked me to do it, they changed it to Sanchez Ramos, more research is needed for medical marijuana. Because in one sentence I said, if you oppose Amendment 2 or agree to Amendment 2, we agree on one thing: more research is needed. If you're against Amendment 2 because we already have Charlotte's Web as of January, there's more research needed on how to use that. If you approve Amendment 2, which will expand the amount of cannabis preparations available as a medicine, still more research is needed. So that was not a bad title to put in. And it got me off the hook as being too much in one direction or another. I left it for the reader. It was the idea, you should vote on something once you understand what the issues are. Many people don't understand. They'll say, why should we vote for Amendment 2 when we already, got a lot of, we have compassionate use of medical marijuana legislation already. It was passed really quickly, right? But unfortunately, it doesn't allow a lot of other applications of the other forms. But, okay, I'll move on. No one asked me about that, but I had to throw that in because November is coming quickly. Are digestive disorders common in Parkinson's patients? Well, one aspect of digestion, yes. I should say, if you think of digestion beginning with the chewing all the way to defecation, yes. All levels of the gastrointestinal system are involved. People develop problems with swallowing, but that's usually later on. Then people early to moderate stages have problems with gastric emptying, so they'll eat something and the food doesn't move on to the small intestine. It kind of lingers in the stomach and can delay the absorption of the medication. And then people develop constipation. All of this is part and parcel of the Parkinson's syndrome. Part of it is because the Lewy bodies, which I told you are typically found in brain, are also found in the nervous system of the whole GI system. From the rectum all the way to the esophagus, you'll find Lewy bodies that develop in the autonomic nervous system. And some people are even using rectal biopsies to confirm early Parkinson's disease. I think it's a bit, told you I can diagnose it clinically. Why do you have to go in and stick a tube in there and get a biopsy? I don't know. Maybe they charge more. I don't know. Just to make that diagnosis. Typically, it's being done for research, not something. I hope none of you have been asked by your doctor, I'm not sure if you have Parkinson's disease, go to the gastroenterologist for a rectal biopsy. I mean, many of you would say, what? And rightfully so. So yes, what do we do about those digestive disorders? Well, often I have swallowing studies done so that the swallowing therapist can give you ideas of the best things to eat, the posture to take when you eat, chin up, swallow, the amount of fluids to take, etc. Do you choke more on fluids versus solids, etc. The next step is, if you have a lot of constipation, is to have plenty of fluids, but also to have fiber in your diet. Sometimes Miralax, which allows normalization of the bowel movements. Those are things you can do. And finally, exercise is really good to stimulate the gut movement. The worst thing for having just everything stick in your and become concrete in your bowels is just doing nothing, because there's a lot of intestinal movement is not just from the autonomic nervous system, which is automatic, but when you're doing like exercise involve abdominal muscles, you're stimulating movement as well. Finally, there are some medicines that worsen constipation, and that medicine I would not use in someone over 60. That's Artane and Cogentin. They not only can cause memory problems, but they inhibit the bladder and the bowel. Number 4, let's see. What diet should I be on for Parkinson's disease? Are there certain foods I should eat or avoid? Typically, I say the answer to that is well-balanced meals. In other words, a nice proportion of protein, carbohydrates, and lipids or fats. We prefer not to have high amounts of fats. That's the traditional notion, because we know by epidemiological studies that people who have high fat diets, like we have in the West, like in Northern Europe, but like they don't have in Japan and other parts of the world, have a higher frequency of Parkinson's disease, whereas people that have more of a fish, vegetable, fruit diet, nuts, have less frequency of Parkinson's disease. That's just epidemiology, is just a little clue. But I think that well-balanced diets are good. A Mediterranean diet is considered to be an excellent diet. The things to avoid: only avoid protein for a period of time if the levodopa seems not to be working. So I normally don't tell people to restrict their protein intake until they tell me they take the Cinemet, it doesn't seem to kick on, and I push it, and they don't seem to get better. So that usually means one of two things, or both. Number one is that they really don't have Parkinson's disease, they have a Parkinson's syndrome, and the problem is downstream of dopamine. It's not with the lack of dopamine. Or number two is they're having so much protein, or they'll take protein supplements, that it blocks the transport of levodopa from blood to brain. And that's well known to happen, but only in more advanced illness. You don't have to worry about that in the beginning stages of the illness, because the amount of levodopa you take in the beginning of the illness is enough to be stored as dopamine in brain. You have enough storage capacity in those dopamine terminals that even though your levodopa levels only last in the blood for about 4 hours, they're maintained for a long time in the brain because you have sufficient buffering capacity, storage space in the dopamine neurons that are still there. As the illness advances, the level of dopamine in the brain reflects the levels of circulating levodopa. So you begin to wear off. And if you have in the circulating blood, along with levodopa, a lot of other amino acids. Amino acids are the building blocks of proteins, and levodopa is one of those building blocks. Levodopa is nothing but a normal constituent of protein that's been isolated and purified and given as a medicine. But if you have in a glass of milk a whole bunch of amino acids, especially what are called neutral amino acids like levodopa, they're going to be competing for the doorway into the brain, because these amino acids do not freely enter the brain. They have to pass St. Peter's Gate, and they're identified as an amino acid. I say St. Peter's. It's an active transport system that allows amino acids to be pumped into the brain from the blood, because there's a blood-brain barrier. So I say there's a gate, right? And if there's a lot of amino acids at the gate, levodopa has to wait to get in and may not even get in. So in those cases, when people are eating a lot of amino acids and they have more advanced disease and the medicine no longer seems to be working, there are two things I can do. Tell them not to eat protein at breakfast and lunch and see if their daytime levodopa effect is much better. And oftentimes it is. Then I would say you have to start playing around with your diet. The other alternative is to use a dopamine agonist that doesn't require transport through the gate. It can just get across, because it's fat soluble. Fat soluble drugs get across membranes. They don't need a special gate like an amino acid. Okay. We're getting there. What does on and off mean in Parkinson's? See, I've organized it logically. They were all random, but what does on and off mean? Well, in the beginning, when you have very early symptoms, you may not even quite recognize that the levodopa is working. And you may not know what on and off means, because you wake up and you're the same and you take Cinemat and this is the beginning stages where the symptoms are so mild that you may not notice benefit. That's why I don't use levodopa if the symptoms are so mild. You just wait till they're incapacitating, then you'll be able to see the difference. The difference between being functional, being able to move and use your hands versus not, is being on. And it varies in each individual. Being on may be no tremors are evident. Being off is a lot of tremors are evident. But typically it's defined as having a restoration of normal motor function. Functional activities are back to normal or close. That's being on. Off is when those motor functions gradually wear off. And gradually means over an hour, 2 hours. In the beginning, 3 doses a day, you may never experience a wearing off because that dopamine is buffered. But later on, you start noticing wearing off after 2 hours. And what I will do is either decrease the interval between the dosing, or increase the dose, or add a dopamine agonist, or add Comtan. But difference between on and off is really recognized quite often in the morning, when you haven't taken a medicine since the night before, and you wake up and you can barely get out of bed. Then you really know the difference on and off. And you take the medication, and you have to wait another hour, an hour and a half before it kicks on. So gradual wearing off is due to the lack of buffering capacity, of storage capacity in the brain. The sudden off is completely different. You may have completely normal levels of levodopa circulating and dopamine in the brain, but you suddenly freeze. That is not due to differences in circulating amino acids or of levodopa. And we don't quite understand why there's that sudden off or freezing episodes. And that's an area of research with perhaps new drugs being developed for that now as we speak. What should I do if I keep falling? Well, what would you do if you keep falling? Don't get up without assistance. You're going to fall if you keep on falling. Oftentimes falling is not, again, it's like the sudden freezing. Has nothing to do with dopamine replacement. The initial stages of falling, yes, maybe a little bit more dopamine may help. To the extent that the falling is due to slowness and rigidity, increasing the medication will help that. But once you get to a certain stage, stage 4, where you're falling, even though your medication levels are fine, you're not rigid, you're not slow, but you fall. And there are many reasons you could fall, but falling as one of the signs of Parkinson's disease, what you need is a lot of physical therapy. You have to relearn a lot of things. If you keep on falling, you have to see a physical therapist, attention to gait and balance, re-education, and use a walker or a wheelchair. Well, then there's a whole series of things about mood and cognitive function. And I try to, so one is serious depression, a part of Parkinson's disease? What is a safe treatment for depression and apathy? How does serotonin and dopamine affect mood? What can I do about tiredness and fatigue? So all of those are kind of related, because depression is actually much more complicated than people believe. There's normal feelings of sadness when things environmentally don't go right. There's normal sadness and bereavement when you lose someone, a family member, a loved one dies. There's that kind of thing. And that has a normal cycle, and you recover, and you don't need medication for that. But there's a depression, it's endogenous depression, has no known external trigger, that we see in Parkinson's disease, often before the diagnosis of Parkinson's disease is made. And about 80% of people with Parkinson's disease have signs and symptoms of depression. What is that? Well, depression usually is inferred to exist from feelings of, well, changes in patterns of sleep and eating is one of the bodily symptoms, but feelings of withdrawal, not wanting to do things you used to like to do, feelings of sadness that persist, emptiness, meaningless, etc. And those are associated with some of the changes that occur in brain in levels of a number of neurochemicals. Just as there is a decline in dopamine, there's also a decline in serotonin and noradrenaline. And when all of those three are below a certain level, there's signs and symptoms of depression. So we often treat that depression and Parkinson's disease. I'd say most of the people that have significant depression or have mild to moderate depression that's impairing their ability to participate in activities that would be good for them, but they say, oh, you don't have, you lose motivation. And there's an overlap with apathy where there's absolutely no motivation without any subjective feelings of sadness. I just don't want to do anything. There's a certain overlap, but they're distinct. With apathy, there's no medicine that's going to help. With depression, medicines will help. With apathy, you need to structure the day for that person because they have no ability to plan anything or carry anything out. So someone who's very apathetic, who's not feeling sad, who's not feeling withdrawn, but just has no motivation, one has to structure it for them. And I'm not going to spend that much time on that. But so the drugs that are used for depression in Parkinson's disease are drugs that elevate levels of serotonin, norepinephrine. We're already elevating dopamine, so we don't have to add something that boosts dopamine. So the drugs that boost serotonin in particular are the SSRIs. The first of the family of drugs, there are many of them, was Prozac or fluoxetine, but we have many others that we use. And then there's some that are the older fashion called tricyclic antidepressants like amitriptyline that elevate norepinephrine plus serotonin. And one is amitriptyline, other is doxepin. And those you have to take at night because they make you very, very sleepy. There's one that I like, it's old-fashioned, also called mirtazapine. It's really good because it improves sleep. And remember, insomnia is one of the symptoms or problems with sleep, non-restful sleep, sleeping all day, not having restful sleep. That can be improved by some of the antidepressants. But this problem with sleep can be independent of depression. Sleep is almost part and parcel of the illness because cycles of diurnal rhythms of daytime awakeness and nighttime somnolence is a function of a rhythmic oscillation of some of these neurotransmitters, including serotonin. So you can correct some of the depression and sleep disorders with SSRIs and some of the other antidepressants. Let's see what else. We're almost there. Oh yeah, why do all patients get memory loss? And memory is also not so simple. There's the short-term recall, and then there's a long-term memory. Everyone, as we all get older, the short-term recall becomes a little more impaired unless you make a real effort and practice it like everything else. It's just very easy to not pay attention to things as you get older because you don't need to. You may not be exercising your short-term memory and so yes, indeed, short-term memory is affected as we get older, and it's even worse in Parkinson's disease, but not anything at all like the decline in short-term memory that we see in Alzheimer's disease. There are some variants of Parkinson's disease that overlaps with Alzheimer's, and there is a pretty significant change and decrease in short-term memory. But the things I recommend to people who feel that their short-term memory is poor is something that my grandfather always told me, is memorize a new poem every week. It can be a short poem, but get it into your head so you can close your eyes and you can recite it. And then to make sure that it really stays there, you recite it to someone that you want to impress. In his case, he was a ladies' man, and he would go to an event, and he would see a beautiful woman, and he would go over and recite this romantic poem from his head until he was 90s, and he had an incredible memory. Everyone thought he was even more brilliant than he really was, but he just focused on memorizing a poem because he used to write poetry. And he's a bit theatrical, so I'll tell you, that's a good way to practice your short-term memory. Now, in the South, what people do is memorize verses from the Bible. I kind of like my grandfather's approach, because who do you want to impress by memorizing the Bible? Maybe if you're a minister, you impress your parish or your people. But that's also good, though. If you're a scientist, memorize the periodic table of the elements. I don't know. Anyway, the other thing to do for short-term memory that really works, because we know how to enhance short-term memory using physical exercise. There's big studies going on throughout North America of cardio-aerobic exercise on a stationary bike to improve memory and motor function. So I used to do this not realizing, just shortage of time. I always used to run. When I was a medical student, there's all this memorization you have to do. In short term, you have to, like really short-term memory. So I would make lists of things I wanted to commit to memory because I had an exam in 2 or 3 days. So I'd make the list, put it in my pocket, get ready, run along the lake for about 5 miles. And I'd be in my mind, I'd look at the list as I'm getting ready, look at it, put it in my pocket, and run. And I'd see how far down the list I could get, and then I'd pull it out, do it again, and get further and further. And by 3 days, I had everything memorized. And it really was retained. It's amazing. Some of those things I learned, I still remember. They're useless bits of information, but still. But, you know, by repetition and doing it while you're getting increased perfusion. I had an architect friend who would run with me, and I told him my secrets. It's funny because I do that with my work. I build a house in my mind as I'm running. He designs it, he does the floor plan, he's drawing it out, you know. And then when he's all done, he goes and does it. So the memory loss, okay. In some cases, we're doing this, people get a little bit short-term memory with agents that we use to treat memory disorders in Alzheimer's. So Aricept or Namenda. So I'm using that more and more in my patients. It may help a little bit with short-term memory. For long-term memory, it seems to be really good in Parkinson's disease and even in Alzheimer's disease until really advanced stages of Alzheimer's where one may not even recognize a family member, faces not recognize where he is in his house, goes into the closet instead of the bathroom, etc. That doesn't happen in Parkinson's disease, that kind of complete memory decline. Oh yeah, the final question is also the final question here was, is there any good research in the horizon? Well, there's some. I'll list the kinds of research that are in the horizon. Research to slow progression or delay it is going on with 2 new drugs. One is called cysteamine. It's Raptor Pharmaceuticals. So it has some preliminary evidence it may protect dopamine neurons. And so there will be clinical trials, I think, going on soon. For those of you interested, you might contact Dr. Hauser at USF. He may be one of the centers doing cysteamine. The other is a new drug called P2B. It's an Israeli company. And that's a curious drug because it has elements that may slow progression, but also alleviate symptoms. That's why 2B. They like to have drugs with 2 actions. Initially, I thought it was a single drug, but I read closely as to what it was. It's really 2 existing drugs in 1 drug, but very low doses of each. And I tell you what they are, you'll be, do I really want to be in that study, the P2B? Well, they're getting a lot of hype for it. But all it is an MAO inhibitor, so rasagiline, which is Azilect, and a dopamine agonist, which is pramipexole. So they formulate it in 1 pill, once a day, long-acting, and they believe that it may slow progression and also alleviate some of the dopamine, some of the symptoms. See, it could be convenient. It'd be interesting to see how it works, but you could do that now by giving long-acting pramipexole and Azilect, which is long-acting. So it may be cheaper to do it that way than to when it finally gets to the market. That kind of research is not that exciting to me. It's using, it's nothing new about it, but you may hear about it in any case. There's research to treat dyskinesias. That I feel is much more promising. And these are called phosphodiesterase inhibitors. There are a number of companies that are making these, and this might prevent those wearing off in dyskinesia symptoms. There's more very early research on immunization or developing a vaccine against the Lewy body, and that would be great because you might be able to prevent the illness. And I think that has great promise. And then there seems to be a resurgence of interest in stem cell research where they use the induced pluripotent stem cells from a person's own skin. But that has a long way to go. There are a lot of problems with the research, but still there's a lot of activity by the people who are very much involved in stem cell research. Finally, this is interesting. It's a new way to deliver levodopa. I thought they found every way. Levodopa can be delivered every way. I mean, now they're developing as a inhaled levodopa into the lung, which is interesting. It might be a good rescue drug. But, levodopa originally, when it was first developed, was intravenous, right? But it kind of it destroys veins. It's very oxidative. So you can't give levodopa intravenously. And then it was developed orally, which is the best way, and the only way it could be tolerated if you gave it with carbidopa. And that's been the mainstay. But then for people that have problems with gastric emptying, problems with swallowing, wearing on and off, they have a gel that contains levodopa, and that's done in the duodenum through a pump directly into the intestine. Again, that doesn't appeal to me, but in young people with motor fluctuations, before the DBS era, they used to do that a lot. And there's still some formulations like that. People have talked about levodopa through the skin, but that won't work because you need too much levodopa to get across through the skin, and it's not really fat soluble. So, but the lungs, through the lungs, an inhaled spray might be really interesting. The problem I see, it might be good as a quicker onset, bypassing the liver-gut, which tends to metabolize a lot of levodopa, so you don't need as much when you inhale it. The problem about that route for me is a lot of people with Parkinson's disease can't take a good deep breath because of the rigidity of the skeletal muscles in the diaphragm. And you have to go, if you have any asthma drugs, you should take a deep inhale to get it into the lungs. But it's a new study that will be coming out of an inhalable form of levodopa. You might hear about that. The DBS research, what's in the future there is a new place to stimulate with the lead that will improve gait and balance, prevent freezing. And that would be a major breakthrough because there's no medications that really help the freezing, the sudden immobility. But this approach might be a big breakthrough. Certainly I've seen video from University of Toronto that shows it seems to be effective. Dr. Oken in Gainesville's done a few cases, and he's excited about it, but it's still a very early stage. And it's in a site that it's a little bit deeper, and it's between the substantia nigra. Substantia nigra has, if I could draw it out, I would show you, but it's almost like the substantia nigra looks, the midbrain looks like Mickey Mouse upside down with the ears are at the bottom and the nose is at the top. The ears are where the cortical spinal tract runs, and just above is the substantia nigra. So imagine the substantia nigra is the hole in Mickey Mouse's ears, right? And just above that is the subthalamic nucleus, and that's where they stimulate for motor fluctuations. But between the ears and deeper down in Mickey's head is the pedunculopontine nucleus, and that's the new target. It's a midbrain target, and it makes sense because this thing is not a dopamine kind of function. It'll happen even if you have normal dopamine levels. You can still freeze. So I think I'll end it there. All right, bye.